Thank you, Matt, for the opportunity to discuss aspiration therapies and novel endoluminal interventions for obesity treatment. No relevant disclosures for the talk. For those who haven't been up to Portland, it's great. A little wet right now, but come on and visit in the summertime. We have a significant need for intervention and innovation. We have about 3 million candidates that are growing and need an intervention for their obesity. Only about 200,000 are actually serviced, less than 7%. Some lack access, some lack coverage, and some really fear the either the wives' tales about surgery, intervention, and just the overall concept of what we can offer them. Many really aren't up for the current options in terms of either things that are really not enough and then things that are a bit over the top. So if someone came in basically looking for a Mazda sedan and the car dealership basically said, look, you either have a Mack truck or a Honda Accord. And they really say, you know what, I just want something kind of in between. So what we're going to discuss is evolutionary, revolutionary innovations from an index perspective. And by evolution, we're talking incremental, initially focusing on things that divert, bypass, or restrict, sleeve, band, that type of thing. And then revolution is totally radical, where we're going to manipulate either with the neurologic systems, biotas, or genetics. So kind of go through there. First up is Aspire, I said late night media. If you've watched Stephen Colbert, he's kind of had some fun with this as well, with his own take on basically drilling a hole in the back of the head, eating your sandwich, and it kind of comes right out as well. But in all seriousness, we'll go ahead and play the video. I don't know if I have control of it or not. There you go. So the Aspire device basically is a percutaneous gastrostomy, which is placed 30 French. A patient eats food, and the Aspire device itself is actually it's able to vacuum essentially off by gravity about 30% of the calories that are taken. The external device is carried in a lanyard. There you are. Not going to touch anything. And it has a extra container that can, basically place either saline or drinking water in it. It's placed around your neck, hooks up to the device itself. A little toggle is switched, and the gravity basically is allowing food within the stomach to pass out. And again, it's typically about 30% of the calories that are initially ingested that are able to be withdrawn. And then once it stops, you can basically squeeze in the water. You could certainly drink as well and dilute the stomach contents, but several hundred cc's of, again, saline fluid is then ingested into the stomach. And this really dilutes things up, swirls it up so that any solid material can be basically marsupialized, morsalized, and then can be vacuumed back out again. So it can be done again and again until the point that the stomach is basically empty. And then, of course, it comes with its handy-dandy pouch that can be then taken home. So there's a 52-week trial with 207 patients. This is one of Chris Thompson's evaluations with the group up in Boston. They randomized 2-to-1 Aspire versus lifestyle modification. And the estimated weight loss or excess weight loss is pretty impressive, about 31% versus 9% with lifestyle modification alone. What they found is pretty typical of that with other percutaneous gastrostomy tubes: abdominal pain, peristomal granulation, the type of thing we see with typical, again, percutaneous access to the GI tract, a couple of severe outcomes as well. Next up, Glycin. This is a startup with Jay Pashrika out of Baltimore, and it's a duodenal, basically applied mucoadhesive polymer, which right now has been in the animal phase placed surgically, but ultimately it would be something that could be swallowed or placed endoscopically. It's a polymer that is soluble in the stomach, but once it hits the duodenal mucosa and the pH there, it precipitates and basically creates a barrier. They have so far done their investigation with diabetic rodents and, again, applied through a surgical access. And what they found in necropsy was that the liner, basically this rubberized liner, was intact at 3 hours. It eventually disintegrates and needs to be reapplied. But in speaking with Jay, the company is basically on the move, getting more funding, and so it'll be exciting to see where these guys are in the next year or so. As Marina was kind of pointing out, so we'll move quickly through the endo windows and magnemosis with the GI fistula presentation. But we'll just leave that. You saw good data from Chris Thompson's group. This is actually just a follow-up with Stephen Mundowitz, where they were able to, again, effectively use this in 10 obese human patients And you can see that patients with type 2 diabetes, hemoglobin A1C dropped from 7.8 to 6. Fasting glucose has dropped from 177 down to 111, and the typical weight loss is around 28 pounds. So initially promising, we'll have to see. My biggest concern there is really internal hernia, and that's not really anything you can address endoscopically, so we'll have to see how that goes. This is Genesis 100, so you can expect this on your late night infomercials. It's basically sugar grain size particles that are a super absorbent polymer that are placed in a capsule, kind of like the little monkeys, the sea monkeys, that you used to put in water as a kid and they'd expand 100 times, or dinosaurs. Except these don't get stuck. So this is basically particles that are released and they swell to about 100 times their normal size. The difference here is that they can mix with food. They're actually made of a biologic polymer that colonic enzymes will break down. The particles will then basically go out with stool. So just think of it as a super fiber supplement of sorts. Again, it's really early there. Most of the data on this is essentially VC startup work. Marina talked just real briefly about Botox, but what we'll also didn't look at, again, with the evolution of restriction, outlet obstruction, or almost induced gastroparesis, the Bariatric Pyloric shuttle, or transpyloric shuttle shown here, is a device that basically is deployed transorally, and this is one of the engineers a couple years ago when we were working with him in the lab, and it's basically a rubberized coil that is longitudinally put into the mouth, and then he's holding it as basically the ball coils back up again. It initially had these ridges that can cause some gastric ulcers. It's now, you can kind of see it very small. And Aurora's hands, the little sac that the coil balls up into, which is super smooth, and they're not having trouble with those ulcerations anymore. And the data on it is actually pretty good. There's a tungsten weight on the very end as a tether that kind of leads on down into the duodenum. A single center, non-blinded trial with 20 patients out of Australia. And the retrieval, this is about as simple as a balloon. You basically pop it in, pop it out, basically 10 and 12 minutes in terms of the device deployment and withdrawal. 3-month excess weight loss was at 31%, and then 6 months is around 50%. Again, there were a couple of patients when they originally were ridges that had some ulcerations, and those have essentially been dealt with. They're now in a larger clinical trial, so it'll be enthusiastic to see how this works. When I first asked the VP about it, I said, there's got to be nausea. I mean, it's basically intermittently obstructing the pylorus. And that was very rarely reported by the initial clinical trial. So it'll be really interesting to see how well this is tolerated overall. Randy Baker in Michigan has FullSense, which is a device that's gone through a couple of iterations, and this is pretty stealthy as well. It's got a web presence, but there's really no major publications on it. It's basically a stent device that literally makes you have a full sense. It's a Cardia, basically dispenser, which is a fully covered nitinol stent, and basically deploys just like a typical stent. The major issue with it, you can kind of see, this is one of the earlier iterations, is anchoring. Right now, or the latest iteration I've been privy to, basically has to fire a pin through the GE junction, which is not the greatest in terms of long-term anchoring, but they're working on it. The device is seen here endoscopically, and then a retroflex view, and then laparoscopically. It almost looks like a cartwheel there. The data was quite impressive, about 75% excess body weight loss at 27 weeks, because you don't have to eat anything to feel full because it's basically there. The problem was that they need to resize these because patients were essentially dribbling off the court. They get their BMIs down into the low 20s and just keep on going. So they've hypothesized resizing these for patients that are all the way down. A couple of websites that have the write-ups down below. There's a phase 2 trial, which is this data here. And more recently out of Columbus, Ohio, a device that basically is a nitinol wire with several small duodenal spheres that are placed, toggles back and forth, essentially to basically slow transit through the duodenum. It's called a statosphere. And initial trials with 31 patients, BMI of 40 versus 10 controls. And device migration was a real problem. As you can expect, there's not really much anchoring it there. Emergency surgery on 2 patients basically prompted the study to terminate. However, those who actually completed it at 3 months did okay, lost about 6 kilos. And so it had some other physiologic impacts as well, kind of like a gastric bypass. So That's probably going back on the shelf for now. They'll need to figure out some better anchoring engineering, and then maybe we'll see it again in a couple more years. And then last, feces to the rescue. As low tech as you could possibly go. This actually came out CNN just a couple of months ago. Could another person's feces help you lose weight? And basically a nice study out of the UK looked at the poop of skinny people and fat people. And really what they found is that the microbiota was much more diverse in folks that were lean than those that were morbidly obese. And so the theory, and this is being worked on in several centers throughout the world, is that by potentially having a fecal transplant or a microbiota transplant of lean individuals' microbiota into an obese person, we may be able to induce some weight loss. So stay tuned on that one. Obviously, that'll be probably a lot of fun for late-night comedy hosts as well. So final thoughts, we need to continue to move forward in terms of innovative technologies. And then lastly, though, we have to show an impact on disease in order to facilitate reimbursement. So thanks.